Good afternoon, everyone. My name is Nicole Cipriani. As you may know, I'm a surgical pathologist at the University of Chicago with subspecialty interests in head and neck, as well as bone and soft tissue pathology, as well as anatomic pathology informatics, and of course, grossing. I would like to thank the AAPA for inviting me here to lecture. It's always a pleasure to interact with our pathologist assistants colleagues, and I look forward to chatting with you after the lecture. So today we're going to be talking about larynxes. Oh, the larynxes you'll gross. There is fun to be done. I love laryngectomy specimens. I think in all of pathology and especially in head and neck, they are some of the most interesting, complex, and beautiful specimens that we can encounter. So I hope you agree with me, and I hope you learn something from this lecture. I have no disclosures. To review our objectives, we're going to identify various types of laryngectomy specimens based on the structures that are resected as well as the primary tumor site. We are going to determine how to section, photograph, and sample various laryngectomy specimens based on these types, as well as appropriately provide a gross cancer stage based on primary tumor site, which is critical for all of these types of specimens. We do have a gross pathology manual up at the University of Chicago. The link is provided here for you. It's freely available. We have most common specimens encountered. Of course, larynx is going to be here under the head and neck section. So feel free to use this at any point during your grossing if you choose. So what is a larynx? In very simplified form, it's a cartilaginous box lined by mucosa with folds and muscles to help us speak. But of course, we all know it's much more complex than that, as evidenced by this very detailed diagram. To remind ourselves, the larynx is anatomically located in the anterior neck, suspended superiorly by the hyoid bone. It is in continuity, of course, with the air and or food passages superiorly, inferiorly, and posteriorly. And so what are those passages? So there's the nasal pharynx, of course, behind the nose, that supplies air. There's the oral cavity that of course supplies food mostly. There's the oropharynx in which the air and food passageways begin to cross. There's the vallecula, which lies between the tongue and the epiglottis, in which food rolls over essentially in order to push the epiglottis down to cover the larynx to protect it from food entering it. Behind the larynx, we have the hypo or the laryngopharynx, in which now is isolated for food. We, of course, have the larynx progressing down to the trachea for air, and the esophagus behind the trachea, of course, again, for food. So just as a reminder, the main air passage is in blue, the main food passage is in green, but of course, some of these air and foods can overlap. The larynx itself contains multiple structural cartilages, which we will go over on this diagram. The first is the thyroid cartilage, pictured in brown. It's a shield in front of the larynx that extends its superior and inferior horns. You can see the superior horn approximates the hyoid bone, and the inferior horn approximates and articulates with the next cartilage, which is the cricoid cartilage in yellow. This is the only complete ring of the larynx. As you can see, it's a little bit narrower anteriorly and much thicker posteriorly. The epiglottis is in green, pictured here, and the smaller corniculate and arytenoid cartilages pictured in purple and blue, respectively. They sit atop the posterior rim of the cricoid on both the left and right sides. Remember that there are three main histologic types of cartilage in the body. Those are hyaline, fibro, and elastic. Why do I mention this? Because it will be important for some of our microanatomy of the larynx. So hyaline cartilage appears sort of glassy. The matrix is made of hyaluronic acids and chondroitin sulfates, as well as some collagen. It looks very homogeneous and purple. Fibrocartilage looks a little more kind of stringy because of all the collagen in the background, as well as very eosinophilic. And lastly, elastic cartilage perhaps looks a little more ropey due to the prominent elastic fibers, which are embedded in the collagen and hyaluronic acid matrix. You can see here on an elastin stain, those elastic fibers perk up. Why do I mention this? Well, hyaline cartilage is present in the thyroid, cricoid, arytenoid, and carniculate cartilages of the larynx, whereas the epiglottis is elastic cartilage. And so when we're looking at histologic sections, we can tell the epiglottis apart histologically based on the fact that it's elastic cartilage, but we really can't always tell the thyroid from the cricoid, or for that matter, the arytenoid or the corniculates. Therefore, when we're discussing our gross description, we always want to document which cartilage we're submitting in those sections, especially if it's not the epiglottis, for us to know exactly what anatomic region we are in, if that makes sense. All right, so here's our view of the laryngectomy specimen from a patient with all of the soft tissues kind of obscuring all of those underlying cartilages, but with the diagram here for your reference. So what we see from the anterior side is the tip of the epiglottis. We see the hyoid bone marked with this white line. We see that the thyroid cartilage is hiding behind all of the soft tissues of the anterior neck. And we also see that there may be some thyroid gland underneath the muscle. There may be some lymph nodes, but we won't necessarily tell just by looking at this anterior surface. Looking from superiorly, we do see the, again, hyoid bone with the white line. We see that the base of tongue would be anterior to the epiglottis, in this case, the upper part of the picture. The tip of the epiglottis is now on the lower part of the picture. And of course, the vallecula, which would connect the base of tongue to the epiglottis. Underneath the vallecula is essentially the pre-epiglottic space, and we will talk about that a little bit later. We also see on either side the superior horns of the thyroid cartilages. Now looking from posteriorly, as you can see, the specimen in this instance has already been cut posteriorly, but let's go over what's below the musculature. So below the musculature and back is the cricoid cartilage posterior lamina. This is the only complete ring, again, of the larynx. And again, we must cut through this to get into the larynx, which, as you can see, has already been done, as I said. Next, we have the thyroid cartilage that's hiding, again, beneath the musculature, with its superior horn approximating the hyoid and its inferior horn articulating with the cricoid. We, of course, see the epiglottic cartilage. We can picture the small arytenoids that are hiding below the folds and sitting atop the cricoid. This rim of mucosa between the epiglottis and the arytenoids is the aryepiglottic fold. Remember that the piriform sinus is a space outside the larynx, essentially on either side of the larynx, on the way to the pharynx and the esophagus. In this case, there really isn't any mucosa of the piriform sinus on this specimen, but you can see a diagram pictured here. What we do see are the bilateral aryepiglottic folds on either side. That is the edge of the mucosa in this specimen. On this specimen, on the other hand, we do see a bit of piriform sinus mucosa as it sort of waterfalls over the aryepiglottic fold. So it would be important to note sort of where your mucosal edges are and whether you're closer to the aryepiglottic fold or waterfalled out into the piriform sinus, as we'll see later. Now we've fully opened that posterior cut in the larynx and we've propped it open with a wooden stick in order to see better the insides. We see the epiglottis. Below the epiglottis is the space called the vestibule, right before you reach the false vocal cord, as well as the true vocal cord right below the false. The false and the true are separated by this little inlet called a ventricle. We will designate the anterior commissure where the folds meet as essentially our anterior midline 12 o'clock. You again remind yourself that we've cut through the cricoid cartilage and we see the first tracheal ring down here. The larynx is split into three main anatomic compartments: the supraglottis, which runs from the epiglottis to include the aryepiglottic fold, the arytenoid cartilages, as well as the false cord. Then there is the glottis, which contains the true cords to about 1 centimeter below. And then the sub or infraglottis, which is, again, about 1 centimeter below the true cords, all the way to the bottom margin of the cricoid, and we stop before we get to the trachea. Just to remind ourselves, there's the anterior commissure where the cords meet, And the posterior midline, where the posterior aspects meet, we will call pole 6 o'clock. So why are larynxes resected? Usually not as a primary treatment for carcinoma. So primary laryngeal carcinomas of any significant size are generally treated by chemoradiation for organ preservation. They may subsequently be resected, i.e. salvage laryngectomy, post-chemoradiation if the carcinoma recurs, and these are generally what we see. Additionally, they may be resected following treatment for carcinoma, resulting in the complications of extreme stenosis, malfunction, trach dependence, and subsequent aspiration in the absence of carcinoma. And so these are basically poorly functional larynxes that end up causing more problems anyway to the patient. These can also get resected carcinoma-free. So what types of laryngectomies do we commonly see? We see standard total laryngectomy for laryngeal carcinomas, usually squamous cell carcinomas. Total laryngopharyngectomies for pharyngeal carcinomas, again, generally squamous. We see total laryngectomies with total thyroidectomies occasionally for thyroid carcinomas that are deeply invasive posteriorly into the larynx and or trachea. We sometimes see total laryngectomies with total or partial glossectomies, perhaps, for tongue carcinomas. There are other various surgical types of partial or hemilaryngectomies, which we won't review in this particular lecture, but we will go through all of the various types of total laryngectomies in detail. Starting with our standard total for laryngeal carcinoma. So here again is that anterior and posterior view, where many of your underlying structures, of course, are obscured by soft tissue, but we now know what's underneath, so we can be careful about how we gross these. So here, in this case, which is different than what we've seen before, is a tracheostomy site. And some of these patients do have tracheostomies because the tumor is quite large, again, can cause aspiration or stridor, and this is for airway access for the patient. You can see that there's a mucosal edge here on the posterior side. There's also a mucosal edge up at the epiglottis on the anterior side. And don't forget that there's also an inferior mucosal edge, that is the tracheal ring. So highlighted here are essentially your superior and your inferior mucosal margins. Technically, the skin of the tracheostomy site is also a cutaneous margin, but usually the carcinomas don't track down these tracheostomy sites. However, the skin could also be considered a margin as well if a tracheostomy is present. So the mucosal margins are generally distant from tumor, and therefore I often recommend that they are snipped off as very thin strips in the fresh or even fixed state to be submitted as en face margins. And in this case, what's snipped off is a very thin, 1 to 2 millimeter edge of mucosa without any adjoining soft tissue that is placed in the cassette en face. So how do we designate these margins so we know where we are in the larynx? So let's walk through. So let's start on the anterior side with the anterior epiglottis that can be separated into the right and left sides, essentially as we loop around to the valleculae. If we travel from the edge here to the posterior side, we will meet at the start of the left aryepiglottic fold. Remember, running from the epiglottis down to the area of the arytenoid. We then have the posterior cricoid area, which can again be separated into a left and right side as well. And in this case, we have a little bit of extra mucosa on the right side. So now we're in the piriform sinus. All right, so this would not be designated an aryepiglottic fold margin. The aryepiglottic fold is right here, and the mucosa is not transected. However, it is transected essentially in the piriform sinus, hence the change in nomenclature on this side. And then again, that margin would be continuous with the sort of epiglottic vallecular margin again on the right side. Just to reiterate, the inferior tracheal ring can also be taken and snipped off en face as your inferior mucosal margin. What about the soft tissue? So generally the outer soft tissue margins are inked essentially up to the mucosal edges. In our institution, we often designate two colors, left black, right blue, just for ease of anatomic orientation. if need be, but one color is also completely satisfactory because anatomy will dictate laterality. Okay, these peripheral circumferential soft tissue margins will be inked and sectioned perpendicularly or radially along with the remainder of the larynx. So these should not necessarily be taken right off the bat. We will see them in our future sections. So the first cut of the larynx, in the fresh state, the larynx is opened through the posterior midline, again requiring the cricoid cartilage, that thick posterior lamina, to be cut. And this I find is usually best accomplished with scissors. So we'll take a scissor right up the posterior midline and make that initial cut. Again, it is propped open with a wooden stick and photographed fresh so that we can see the region of tumor. In cases where tissue is necessarily not needed for tissue banking, I do recommend that these get fixed overnight because sometimes the tumor can be large and boggy, and it is easier to cut in the fixed state. However, fresh sectioning is also appropriate if that is what's requested at your institution. In this case, you see the tumor mostly as a kind of hemorrhagic ulcerated area. Usually the laryngeal tumors are centered in the anterior larynx, as in this case, they tend to be ulcerated. And don't let that fool you because they can actually be very deeply invasive anteriorly, even if they don't have much posterior proliferation into the lumen of the larynx. Again, here's the tracheostomy site from the mucosal side. And what are these little kind of reddish brown structures that I'm highlighting here with the yellow circles? So these are important for orientation. These are the thyroarytenoid and vocalis muscles that run along the level of the true chords and can help identify the level of the glottis, remember the true chord, when they are effaced by tumor, as in this case. So those are nice anatomic landmarks to help you identify the glottis if there are other structural anomalies that are obscuring the larynx. All right. The reason we need to know where the glottis is to determine the epicenter of the tumor, as stage is based on location, being either centered on the supraglottis, centered on the glottis, or centered on the infraglottis, all three examples seen here. For staging, I'm going to refer to the College of American Pathologists templates that are all available online. They're of course based on the AJCC staging. We are currently in the 8th edition of the AJCC stage, and the CAP templates reflect those. So the larynx, as you can see here, is separated into the supra, the glottis, and the subglottis. For all of those sites, T1 tumors are essentially localized to that respective subsite. Many of these smaller tumors are treated with microlaryngoscopic excision endoscopically using laser ablation, so we don't often see these very small T1 tumors. T tumors extend beyond the one subsite, but are still confined within the larynx. And T3 and T4 all essentially extend into some laryngeal, paralaryngeal space or beyond the larynx. And we often see T3, T4 tumors as salvage laryngectomies. In our case, the tumor spans all the way from the supraglottis to the glottis, down into the subglottis. So this would be considered a so-called transglottic tumor. Transglottic meaning crossing compartments vertically. So including supra and glottis, including glottis and sub, or including all three. Therefore, this tumor is not localized to one subsite, so it is at least T2, and perhaps more, depending on how far it travels anteriorly. All right, the second step in our sectioning of larynxes of tumors that are anteriorly located, which is most of them, as I said before, is our midline sagittal cut through the anterior commissure at 12 o'clock, or approximating where the anterior commissure is, if, as in this case, it's quite effaced. This, as I said before, can be done fresh or fixed depending on various needs, like exposing tumor for tissue banking, etc. So here is a fresh cut through the larynx. We sort of bookended it and separated the book into left and right halves. You can see the anterior half of both sections is in the middle. The posterior or mucosal aspect is on either side. And you can see these are mirror images, yes? So The tumor in this case is quite large. It disrupts the thyroid cartilage on both sides and starts to creep out into the anterior musculature. So this tumor is quite large despite its very minimal ulcerative appearance on the mucosal surface. The next step in sectioning of this specimen would be radial cuts perpendicular to the mucosa in an attempt to achieve sections that would include mucosa, cartilage, tumor, and whatever anterior or peripheral structures are in that plane. We sort of circle around the larynx and we finally end up reaching posterior. So how does that look conceptually? So this is a view superiorly looking right onto the top of the larynx. You can see that the first cut, which we've made initially, right, was our posterior midline cut at 6 o'clock. Our second cut is going to be that anterior commissure cut at 12 o'clock. I didn't mention this earlier, but usually instead of scissors, this can be achieved with a long blade. You may encounter friction if it's a very calcified cartilage. You may encounter a stop at the hyoid bone in which you may have to use a hand saw to get through that. But that would be, again, your second cut already, which we've seen. Those remaining cuts are essentially taken clockwise around the larynx. In this case, starting from essentially 1 o'clock, we're sort of walking our way around with our cuts until we get to 6 o'clock and doing the same procedure on the opposite side. So we end up with sort of a clock face around the larynx. Your sections may be slightly thicker at the outer edges, as you might imagine, sort of a wedge shape, which is okay, because this will still allow us the best view of all of the compartments and their relationship to the epicenter of the tumor. So once we have these sections, we need to evaluate the laryngeal spaces and tissues beyond the larynx. So this is very important for gross staging of laryngectomies. So the laryngeal spaces are the paraglottic, the pre-epiglottic, and the post-cricoid. Of course, we will determine invasion into the actual laryngeal cartilages, mostly cricoid and thyroid. And then the tissues beyond, right? The strap muscles, the thyroid gland, in some cases, the esophagus. So here's an example of a relatively uninvolved larynx half, the right half, showing the posterior view on posterior edge on the right and the anterior edge on our left. So here's the epiglottic cartilage highlighted. Here is the pre-epiglottic space, which is the adipose tissue anterior to the epiglottis. So it makes sense, pre-epiglottic before the epiglottis. We now have the thyroid cartilage where I've highlighted the inner cortex, which is approximating the mucosa, and the outer cortex, which is of course approximating the soft tissues of the neck. You have the paraglottic space, which is a potential space between the vocal cord / mucosa and the thyroid cartilage. So this isn't a very large space as the pre-epiglottic space is. It's quite small and mostly a potential space. Here we see the cricoid cartilage, again with its narrow anterior lamina and its wide posterior lamina. And the post-cricoid area is again that scant or potential space posterior to the cricoid cartilage, which may be invaded by anterior tumors that wrap around or by the rare posterior tumor. Don't forget the first tracheal ring, just inferior to the cricoid cartilage. All right, so once we have those radial sections, in our case of this bulky tumor, right, we again remember to see the epiglottic cartilage. We see the thyroid cartilage, which has been distorted by the tumor. And we see that the tumor itself is sending little white islands into the strap muscles. So we already have a good gross stage of strap muscle invasion. We also see it in a different section as we get a little more laterally wrapping around to the thyroid gland. We see that it is starting to approach the tip of the thyroid gland, again important for staging. A different view highlighting the epiglottic cartilage and the anterior border of the epiglottis, and the tumor nodule in the pre-epiglottic space. I will remind you, because you can see it here quite nicely, that the tissue above the pre-epiglottic space is essentially in continuity, right, with the vallecula. And this is a vallecular or a superior soft tissue margin. So here is your mucosal margin of the epiglottis / vallecula. And this adipose tissue that's been inked is your superior / vallecular margin. So in this case, you can actually get a distance and sections of the tumor to the margin superiorly. Similarly, we see the thyroid cartilage with the anterior border outlined, and the tumor is invading the skeletal muscle anterior to the thyroid cartilage. And lastly, we see the thyroid gland highlighted with, again, the tumor kind of invading the superior tip of the thyroid gland. In this case, the anterior margin is going to be this inked skeletal muscle tissue, which again, you can get a measurement to and sections to include that tumor to anterior margin. Okay. So what's the stage in this case? So if I haven't said it enough already, staging is best done on gross exam. So documentation of those intra and extralaryngeal sites by tumor, both by photographs as well as by correct descriptive sampling is very crucial for final staging. But just based on these photographs, we already know the patient is T4A, right? Because we've invaded beyond the thyroid cartilage into the soft tissues of the neck, i.e. the strap muscles, and in this case, a little bit of the thyroid gland. All right, so just to reiterate those soft tissue margins, what you will be looking for, again, after your radial cutting is going to be the superior, which is that vallecula / base of tongue area. You're going to be looking at the anterior, which is that strap muscle area. You're going to be looking at the posterior, usually not of terrible concern for these laryngectomies because usually the posterior is uninvolved, but should always be evaluated. And then that lateral, which we don't really see in this photograph, but it's sort of opposite us, right? If we cut right through that 9 o'clock pole, that outer edge would be our bilateral margins. That's where we sort of approximate the thyroid gland kind of on either side of the larynx, if that conceptually makes sense. So again, gross photographs and appropriate sampling with descriptions of where you are in the larynx, what clock face you are at, and what cartilages you are sampling is going to be crucial. All right, so at sign out, the diagnosis and staging is best accomplished with this gross histologic correlation, crucial for laryngectomies. So photography of the larynx, description of those sites, those spaces, and those structures is very meaningful. So at UChicago, each larynx does undergo gross review with both the pathologist and the prosector, either a resident or a PA, to facilitate sign out. Because once the pathologist has seen it, we sort of know what to expect on the slides, and the resident or PA has a better understanding of what we will be looking for and what approach and attempt to take in that sectioning. So we love looking at our gross laryngectomies. I encourage you to call your pathologist. It's very meaningful, I think, for both parties. Okay, so moving on to our second most common type of laryngectomy, which is going to be our laryngopharyngectomy for pharyngeal carcinoma. These are performed for tumors involving the posterior and or lateral pharyngeal walls most commonly. The larynx itself may or may not involved, and the tumor may in fact extend into the upper esophagus, which is of course in continuity with the pharynx, right? So here is again that superior view, seeing the epiglottis most anteriorly, seeing the lumen of the larynx right behind it, seeing the lumen of the pharynx posterior to that, with the posterior pharyngeal wall cupping the bottom and the lateral pharyngeal walls on either side. Here we have the inferior view flipped over. We have, again, the lumen of the trachea. Here we see the tracheal ring, right, which is sort of C-shaped. And then we see the lumen of the esophagus posterior to the trachea. So one may choose, in this case, to take both the inferior tracheal and the esophageal ring margins en face as 2 millimeter snips and cassette those right away. You have both of your mucosal inferior margins done in this case, if that's what you choose to do. But now in order to determine sort of how to open this specimen, where the tumor is going to be crucial. So we want to either palpate, we want to kind of pry open and visualize, or we want to use radiology to identify the location of the tumor so that we know where to make our first cut. So in this case, if the tumor is more predominantly right-sided, we may want to cut along the left lateral pharyngeal wall as close to the larynx as you possibly can. Conversely, if it's a more left side predominant tumor, where you may want to cut along the right lateral pharyngeal wall, again, right up as close to the larynx as you possibly can get, and free open that pharyngeal flap. So here's what it looks like in a case in which we have a tumor centered essentially quite neatly on the posterior pharyngeal wall, and we've cut along the left lateral pharyngeal wall. When a tumor is this centrally located, you can really choose either side to cut. It doesn't really matter. What do we do now about the mucosal margins that we've exposed? So we have the superior posterior pharyngeal wall margin, right, which is in continuity with the posterior pharyngeal wall up in the oropharynx, okay, still in the patient, of course. Remember, there is no superior anterior pharyngeal wall mucosal margin. This is essentially just the folds of your larynx, right? The most anterior mucosal margin that you're going to have is, again, that mucosa as it wraps in front of the epiglottis in the vallecular area. However, inferiorly, you do have the margins of the lower pharynx / upper esophagus, depending on what level you're at. In this case, we have the posterior inferior pharynx / upper esophagus and the anterior inferior pharynx / upper esophagus that before this was open, right, was just that little ring. Okay, the next step would be to amputate the posterior pharyngeal wall on the attached side if you can make a clean break of it, as in this case. This is that amputated posterior pharyngeal wall specimen. You've essentially created a very tidy mucosal ellipse. And so I really like these laryngopharyngectomy specimens because you can really make tidy little compartments out of them in cases like this. So we see the mucosal aspect, i.e. the view from the sort of anterior portion, and the deep aspect, the view from the posterior portion, right? So the posterior or deep pharyngeal wall musculature margin is inked, and in this case, inked differentially left and right, again, to maintain our laterality. So this amputated portion can then be treated like any mucosal ellipse, where you have your superior posterior pharyngeal wall margin can be taken in perpendicular sections. Your inferior posterior pharyngeal wall or esophagus margin can also be taken perpendicularly, again, unless you've already taken it as an en face donut. And then the remainder just central sections. Remember that your left and right sides of this particular piece of tissue, right, are not margin. They're your cuts. So those are not true margins. Really, the only true margins are that superior mucosal, that inferior mucosal, and that soft tissue deep. So what remains is essentially, in this case, an uninvolved larynx. So we've now cut through the classic posterior cricoid cut with scissors. The larynx in this case can receive standard sectioning and representative sampling as long as it is essentially uninvolved by tumor. I would still recommend you section it as you normally would a cancer larynx just to evaluate it thoroughly. But in this case, representative sampling of the cords, the folds, any additional anterior soft tissues or thyroid glands would be appropriate. In some cases, however, the posterior pharyngeal wall tumors do sort of creep onto the larynx, as in this case, it's sort of spilling up onto the right area epiglottic fold involving the piriform sinus on the right side. So in this case, you may want to take your sections differently. You may want to actually take sections that include both that posterior pharyngeal wall and that involved portion of the larynx in order to determine if there is invasion into the cords, into the thyroid or cricoid cartilages, because again, that will be important for staging, but your margins can still be taken as those perpendicular sections. So speaking of staging, so in this case, pharyngeal wall tumors are not larynx, right? So we do not refer to the larynx synoptic. We refer to the pharynx synoptic. The pharynx synoptic is separated into the nasopharynx, the oropharynx, and the hypo or laryngopharynx. In this case, it will be the hypo or laryngopharynx. These tumors are staged both by size by involvement of the various subsites, which are highlighted in red, as well as extrapharyngeal structures like thyroid or cricoid cartilages, esophageal mucosas, etc. So the subsites of the pharynx are, as you can see here, the bilateral piriform sinuses, the lateral and posterior hypopharyngeal walls, even that postcricoid region right behind the larynx. I've highlighted here in a little bit bolder line the esophageal mucosa because you may be asking yourself, well, where does pharynx end and esophagus begin? And that can be a challenging question to answer in the ex vivo state. In a patient, the esophagus begins at the lower border of the cricoid, which corresponds also to the lower border of the C6 vertebra, and contains the cricopharyngeus constrictor muscle. Now, it may be difficult or impossible to know with certainty if the tumor involves the esophagus without clinical information. So whenever I have these specimens, I do refer to radiology and clinical notes to see if there is a clinical perception of esophageal involvement, because ex vivo, right, these tissues can retract and shrink and change shape, and therefore the actual border of the esophagus can be sometimes challenging to tell, even if we do have the cricoid, in our specimen, right? Because we're not going to be having hopefully a vertebra in our specimen. Our only frame of reference might be that inferior border of cricoid. Okay. So what are the stages in our two examples of our laryngopharyngectomies? So just based on size, they're both about 3 centimeters. The one on the left involves essentially one subsite, which is the posterior pharyngeal wall. So it remains a T2. The one on the right involves at least two subsites: the posterior pharyngeal wall, the lateral pharyngeal wall, the piriform sinus, right? This is certainly at least T2, but could be T3 if either the larynx is clinically fixed, so again, something to correlate with the clinical notes, or if the carcinoma now invades the thyroid cartilage, which will be documented by your sections, your photographs. All right. Moving on to our third type of laryngectomy, which is that performed for a very aggressive thyroid carcinoma. These could either be well-differentiated papillary or follicular carcinomas that invade posteriorly, or sometimes for the very biologically aggressive anaplastic thyroid carcinoma that does have high rates of laryngotracheal invasion. So thyroid carcinoma, always be mindful of the staging system of that originating carcinoma. For thyroid, invasion posteriorly into the trachea, into the larynx, or even into the esophagus, all of it is T4A. So once you get this specimen, the stage is already there. In most cases, staging is going to be less important. Therefore, direction of sectioning can be done however you like. Most important is just going to be document the subsites that are involved, of course, by both your photographs and your sections. In this case, we have a very large specimen, which is a total laryngectomy, a total thyroidectomy, and even some redundant neck tissue, which is representative of neck dissections. So many pieces in this specimen. To remind ourselves of that T stage, here's showing T4A for thyroid cancer, gross extrathyroidal invasion into either anteriorly, right, the subcutaneous soft tissues underlying the skin of the neck, or posteriorly into the larynx, trachea, or laterally even into the recurrent laryngeal nerve. Sometimes clinically, the recurrent laryngeal nerve unfortunately has to be resected in these patients. Again, that's going to be something to refer to in the clinical notes to determine whether you are expecting the nerve in your specimen or not. Here, for thyroid cancers, I generally recommend just a beautiful serial axial cross section through the specimen so that we can walk our way through the tumor. Because this is originating external to the larynx, right? It's usually originating in the trachea, cricoid area, and invading posteriorly. So here we have sections from inferior to superior, with the anterior aspect of each slice on the upper part of the picture and the posterior aspect of each slice on the lower part of the picture. So we have our tracheal ring as seen here with some blurry yellow tissue. We then move upwards and we start to see more clearly the tumor as it invades adjacent to the trachea, and then even perhaps creeping around posteriorly to invade the tracheal mucosa. We then start to approach the cricoid cartilage, again, that posterior thick lamina. We move forward, the cricoid cartilage starts to come around into a rim. And again, we sort of walk through the tumor inferiorly to superiorly. The bulk of it is sort of at the level of the trachea/lower cricoid. This is a second example of a different specimen, more in the fresh state as opposed to the fixed state. Again, you could see the tracheal rings. You can see this friable reddish tumor, in this case, kind of wrapping around posteriorly to invade the trachea from the posterior surface and then undermining the mucosa, as you can see here in this picture. Remember that the tracheal rings are essentially C-shaped, and tumors sometimes have a hard time invading through cartilage because it is avascular. And so they tend to take the plane of least resistance. And so sometimes that's tracking around the tracheal ring to get into the space, right? The opening of the C, or between the tracheal rings to get into the mucosal tissues. All right. So sometimes path of least resistance is how these tumors travel, as evidenced sort of by creeping in to the hole in the C and then undermining the mucosa. Right, so how do we sample these then? So once we have our cross sections, they can be hole mounted on large format slides if your lab is able to do that, but they can also just be blocked in, sort of using multiple cassettes with an appropriate diagram. Here's a recommendation of how you might try to block in one of these cross sections, but certainly speak with your pathologist if there's ever a question on how much sampling is needed in these cases. Here's an example of one of our hole mount sections showing that C-shaped tracheal ring with the defect where the tumor sort of encroached. The hole mount slides are generally around 3 by 2 inches. And so you can sort of fit, these specimens pretty much on a hole mount slide if able. I would argue not to submit your entire case this way, maybe just one for academic reasons or for beauty, but really if any sort of molecular testing or immunohistochemistry is needed on this tissue, these are very challenging specimens to cut. You cannot stain them automatically, right? You have to manually stain them. So still submit sections in your regularly sized cassettes for ease of future processing. But, for academic reasons and interest, I also like to do one hole mount if I can. All right. And our last type of specimen, which is going to be our total laryngectomy plus glossectomy for tongue carcinoma. So if I haven't said it enough, again, remember, always look at that staging system of the originating carcinoma to know what we're looking for. So in this case, we're going to be looking for tongue carcinoma. So the tongue is separated into the anterior tongue, right, before or anterior to the circumvallate papillae, and the posterior tongue, posterior to the circumvallate papillae, which is essentially the base of tongue. So remember, the anterior tongue is staged with the lip and oral cavity system, and the base of tongue is staged with the oropharynx, i.e. the pharynx synoptic. Yes, we remember the pharynx synoptic from before. All right, so this is a view of a total laryngectomy, total glossectomy specimen with essentially a posterior view showing the larynx back here with the entire tongue on the left aspect of the photograph. Flipping it over to the anterior view, we see the soft tissues of the neck. We see a little bit of the superior trachea, and we see the tip of the tongue here. As you can see, there is an erythematous area at the base of tongue starting to encroach up into the valleculae. This is going to be a base of tongue, i.e. oropharyngeal primary. Regardless of whether you are, if you are in the oropharynx, your T stage does depend on HPV status. So whether you are HPV unrelated oropharynx or HPV related, HPV positive oropharynx, your staging system is different. However, once you have invaded the larynx in either, you are always T4A. So in this case, you don't need to know whether the patient is HPV positive or not, as long as you know it's a base of tongue oropharynx primary. Once it's in the larynx, it's essentially T4A. Other than that, as you can see, it's based on size as well as invasion of other more advanced structures. Okay, So what I would recommend in this case, which is what you see here, is a complete mid-sagittal bisection through the larynx and the tongue. The only piece of resistance, again, you might encounter is the hyoid bone seen here. So again, you may want to take a handsaw to get through that, and then your specimen should open. We see here the sort of C-shaped tumor, which is originating in the base of tongue, sort of flowing onto the vallecula and then undermining the anterior aspect of the epiglottis, as seen here, and even approaching that anterior soft tissue margin, which is essentially going to be the extrinsic tongue musculature area. Here's the opposite section. Here's the left half of the specimen showing mirror image, very similar findings, right, where the tumor undermines the anterior epiglottis as it has flown over from the valleculae to the base of tongue, or vice versa, I should say. Again, recapitulating that encroachment on the anterior soft tissue margin. So once we have this, it's beautiful, very photogenic, very sad for the patient, but what do we do with this specimen? So additional sections could be taken sort of parasagittally, so right next to midline. You may want to block in that area of tumor, wrapping around from the base of tongue to include that margin, the valleculae, the epiglottis, and you've essentially sampled many of the relevant areas here. Or you can also take perpendicular sections and then sort of walk through the tongue, the vallecula, the epiglottis, the larynx, etc. And so in this case, we actually did a little bit of both. So we ended up doing a whole mount of a parasagittal section, seeing that base of tongue tumor flowing under the vallecula in the anterior surface of the epiglottis, and even maybe poking through to encroach on the opposite surface, the laryngeal surface of the epiglottis seen here. And we can also recapitulate that encroachment on the anterior soft tissue margins that you can see here are inked a little bit in black, right? So that is our parasagittal home mount section. Then we did subsequent perpendicular sections where we can walk through. In this case, the tongue portion is on the bottom. You can see the brown musculature of the tongue. And as we get closer and closer and closer to the larynx, we start to get our cartilages, right? And then we finally end up in the larynx. And so we can walk through the specimen in this direction as well. Bonus. So we didn't talk about this earlier, but I thought I'd throw in a bonus specimen, which is going to be soft tissue tumors. So what soft tissue tumors are you going to expect to see in the larynx? Like not many at all. True. However, if you are going to see a soft tissue sarcoma, it's probably going to be a chondrosarcoma. These are very rare, but they are the most common sarcomas of the larynx. Benign chondromas of the larynx are thought to be extraordinarily rare to non-existent. So mostly if you see a cartilaginous tumor, it is probably a chondrosarcoma, or at least should be sort of treated as such in the high likelihood that it is. So here is our standard mid-sagittal section through the larynx, again, with your mucosal posterior side on the left, the anterior on the right. And so because this tumor was sort of centered anteriorly, just like our classic squamous cell carcinomas, we have taken the same approach to sectioning. The chondrosarcomas tend to arise from the cricoid cartilage, so expect to see them in that region. They can protrude posteriorly and cause stridor, trouble breathing because of their involvement of the lumen. As you can see here, they can also flow anteriorly into the soft tissues of the neck. So for soft tissue type of tumors, stage is site specific. So for sarcomas, we want to refer to the sarcoma staging system that's specifically of the head and neck. In this case, it is based on size, 2-4 centimeters, as well as what structures are involved. So again, the direction of sectioning of the larynx here is also somewhat less crucial as long as you tell me where you are and what is involved. So again, these can be treated in a number of ways depending on the specimen and what structures are involved. If it's a bit lower, you may also consider doing the transverse sectioning like we did for that thyroid carcinoma. All right, so in the end, did we accomplish our goals? Hopefully. We've identified various types of laryngectomy specimens based on the structures resected, but more importantly, that primary tumor site, right? Is it for a primary laryngeal carcinoma? Is it a laryngopharyngectomy for a pharyngeal carcinoma? Is it for a thyroid carcinoma, perhaps a tongue carcinoma, or even for a very rare soft tissue sarcoma? We've determined how to section, what to photograph, and how to sample these laryngectomy specimens based on the tumor types, and critically provide that gross cancer stage based on primary site. So at this point, I'm happy to open up the floor for questions or comments. I'm looking forward to chatting with you.